Can you see my slides, Sandeep?
Yeah, we can.
Okay, so I'm going to, you see, foramen magnum tumors are very common neurosurgical issues, and I'm going to touch several tumors which I have dealt, which are common tumors, and I will like to introduce some points which I have found to be useful, and I have found them to be effective. So foramen magnum is a big area and a beautiful area, as you can see. The neck is unique. Majority of muscles of the neck are located in the nape of the neck. Very few muscles are located in the front of the vertebra, and relatively few muscles are located in the lateral. So posterior is the most heavy, anterior is the weakest, and lateral. These are meant for the movements that are taking place in this region. So just take an incision in the posterior pharyngeal wall and you will get onto the bone. So there is hardly, except for a little bit longer scoli curtain, there is nothing much here. So transoral surgery for removal of tumors anterior to the cervicomedullary cord had become quite popular. And Alan Crocker during those days just take an incision here, drill the bone, and for these kind of tumors, take an incision in the region, no muscles here, just remove the odontoid process and come to the tumor. So this was considered to be a good operation, but unfortunately it never took up and never saw the light of the day. And this was one letter where I had actually criticized that this approach is not such a great approach and this may not be a useful approach. Second thing is lateral approaches and extreme lateral, far lateral approaches to anteriorly located foramen magnum tumors had become very popular when Sen and Shaker introduced this extreme lateral approach in 1988, and I was part of their team. The exposure involves exposure of the vertebral artery, mobilization, and resection of the condyle. And some of these aggressive approaches have been discussed in my book, which was written a long time ago. In the interim, we introduced this minimal invasive supracondylar infrajugular bulb approach to anteriorly located foramen magnum tumors. So this was a small modification that we did in 1994, about 30 years ago. Other thing is, during that time, this extreme lateral and all those approaches were becoming very popular. And in Neurosurgery journal, we had introduced that you can do these approaches only by a relatively midline approach, remove the foramen magnum, part of the atlas. More important issue in these cases is learn the art of breaking the tumor, learn the art of demolishing the tumor without much coagulation, working between the nerves, working within the perforators. That art has to be learned, and that exposure, you may minimize the exposure. And for me, this article I had written in 2001, with 17 cases over the next 24, 25 years, we have got several hundred patients where we have done with this exposure, no condylar resection, no vertebral artery mobilization. So these tumor is the game, is the dissection, art of breaking the tumor, art of demolishing the tumor, working between the blood vessels, working within the cranial nerves, and having a very good anatomical understanding. Obviously, you make a mistake and you demolish. You cannot make a mistake. The tumor may go right from one side to other, and you have to, all these things can be done with a minimal exposure. We have done some absolutely dangerous and difficult ossified anterior foramen magnum tumors, meningiomas, with this minimal exposure. I will show you these images and you decide for yourself whether they are easy or not. This is completely ossified. You see this bone, and the artery is within the ossification. So this makes both this combination, firm tumor, difficult area, but added by just conventional approach, and this tumor. So this was a dangerous tumor. This is another very dangerous tumor. You see ossified, completely solid, and the arteries are encased in a rocky tumor. So difficult tumor, dangerous tumor, but you can do it within the minimal approach. This is another tumor of similar plan, ossified. See the vertebral artery between inside the tumor, difficult tumor. Essentially what I mean to say is You can do these tumors with minimal exposure. You can do this tumor if you know the art of breaking the tumor, if you know the art of dissecting the tumor. So if this tumor is going right in front of the brainstem, going across the midline, you can do this operation with minimal exposure. So during those days, I was in a cavernous sinus anatomy. I was developing my experience with dura. So we described extradural approach to tumors involving cavernous sinus in 1996. We also described interdural approach to trigeminal neurinoma working within the dura. So this tumor, for the first time in the literature, we removed trigeminal neurinoma without any craniotomy by understanding the dura and understanding the tumor. So this was the tumor in 1995 we removed without craniotomy. This tumor, trigeminal, going in the posterior fossa, just this exposure working within the dura in 1994. C2 neurinomas are very common foramen magnum tumors, and they are the largest ganglion of the spine, like Gasserian ganglion is the largest ganglion of the cranium. Trigeminal neurinoma is of 3 types. Inside the middle fossa is interdural, inside the posterior fossa is intradural. This is what we had said. Now we say that even the posterior fossa part can be intradural. Same thing we had said for C2 neurinoma. We had said that this part of the tumor is intradural. So we used to do laminectomy for this. And this article in 2008, on the basis of experience with 60 cases, we said that this part of the tumor is intradural. But later, we wrote another 50 cases where we said even this part is intradural. So you can do these tumors just by making the incision in this part and working within the dura. So over the period, we have done several cases where we have, as you can see, more than 50 cases once and 60 cases on the next. Open the dura, work within the tumor, within the dura, and you can remove this tumor. Even the extraspinal part is within the dura. So this tumor, this was the first time in the literature we described that these tumors can be removed without any bone work. Like we described, this tumor can be removed without any craniotomy, without any laminectomy. So this is a very straightforward tumor. Only thing is, open the dura, work within the tumor, and you can remove this tumor in very, very quick time. Even the extracranial part is within the dura. Other important tumor in the foramen magnum is lower cranial nerve tumor. So we described that lower cranial nerve tumors are interdural in location. My feeling is if you do not have this concept, removal of lower cranial nerve neurinomas can be dangerous. This was the only article in the literature we said that with this interdural strategy, you can improve the function of the lower cranial nerves. So if this is the tumor within the mastoid, extracranial, intracranial, expose widely, open the dura and work within the dura. So these foramen magnum tumors are interdural even if they are extracranial, work within the dura for all the 3 compartments, and that is the trick of removing these tumors. Hypoglossal tumor is another complex intracranial and foramen magnum tumors, and you have to really understand the symptoms and understand the strategy of removing. Endodermal cysts are another important foramen magnum tumors, and most important in endodermal tumor is to identify the tumor on the basis of radiology. So on T1 weighted image, they are white inconsistency, and on T2 they are dark. Like this one, on T1 they are white, on T2 they are dark. Most important thing is they are like abscess. You open the lateral wall, that wall is thin, and you can remove, they just come like fluid, and these difficult looking tumors can be done in a very beautiful manner. Long time ago, I had reported 7 cases, but now this was in 2006, 2005. Over the next 20 years, we have got several cases where we have done. So these are benign lesions. These are like colloid cysts. You don't have to actually remove the entire wall, which may sometimes become difficult. And because of the extension from one side to another side, evacuate the cyst. Soft calcifications can be there within the tube, within the cyst. So these are very straightforward, very beautiful. You don't need to do any major kind of exposure. just have a lateral retrosigmoid exposure, expose the wall of the cyst, and remove the. Sometimes we have identified cases where the cyst is going right inside the brainstem, and this is another endodermal cyst going right inside the brainstem, and we had reported this endodermal cyst. And there can be another thing is retroodontoid pseudotumor. This tumor is not exactly the tumor. This is an osteophyte and indicates atlantoaxial instability. You don't need to remove this tumor. So this retroodontoid mass is an evidence of craniovertebral instability. Retroodontoid pannus is an evidence in rheumatoid arthritis, is an evidence of craniovertebral vertical instability. This is buckling of the ligament. We said that there is no need to remove this pannus. Retroodontoid cyst is an evidence of unstable atlantoaxial joint. You don't need to remove this. You just need to stabilize this tumor. And there can be immediate postoperative disappearance of this retroodontoid cyst and tumor. There can be other tumors like fungal infection in the foramen magnum, osteoblastomas in the foramen magnum, osteoclastomas like this, and this huge tumor, the head is separated from the rest of the spine. How to remove and what to remove is a big chapter. You can have huge neurinomas, you can have osteoblastomas, and you can have other kinds of tumors. So this is my presentation, my dear Sandeep. And this is another tumor, which is a end plaque kind of tuberculous granulation where we have to do decompression. Lipomas can be there, which can go across the compartments, and chiari malformation and syringomyelia is another issue which can go across the compartments. So thank you very much.
Oh, thank you, Dr. Goel, for an excellent presentation.